Ladies and gentlemen, thank you for your patience in holding. We now have your presenters in conference. Please be aware each of your lines is in a listen-only mode. At any time throughout today's presentation, you may direct your questions to the chat window located on the right of your webinar. It is now my pleasure to introduce today's first presenter, Mr. Chris Hund.
Thanks, David. Hi, everybody. Welcome to the July TeamSTEPPS monthly webinar. This webinar is partnering with your malpractice insurance program to improve safety in surgery. TeamSTEPPS is a part of a multifaceted program, and we'll be joined just in a few moments by Dr. David Feldman to talk about this. Just a few quick things, though, to start off, some rules of engagement. First off, as you probably already realized, the audio for the webinar can be accessed in two separate ways. So you can listen through your phone, or you could listen through your computer. If you've chosen to listen through your phone, then what I need you to do right now is look at the top of your screen and you'll see a little speaker icon. Make sure you mute that speaker icon, because otherwise you'll get the sound from the webinar coming both through your computer speakers and through your phone, and it'll kind of be that radio effect where there's that weird echoey sound when you call into a radio station to talk to somebody who you're listening to. So please do that right now if you're listening through your phone. We're going to do a question and answer session at the end of this webinar. And the way that we like to do Q&A on these is via written questions. So as you think of them throughout the course of the webinar, please use the chat function, which you see on the right-hand side of your screen, to type in any questions you might have. The reason we do this is because a couple things. We found that this way people don't forget their questions as they're going along. If they think of something to ask David, they just send it in to us. Number two, it allows us to kind of come up with a coherent narrative maybe for the Q&A session. Sometimes it works, sometimes it doesn't, but this way we're able to make everybody's questions kind of flow together, and we could delete duplicates if people are asking similar questions. Number three, the reason that we do this is if we don't get to all of the questions, this way we have a record of the questions we didn't get to. And David will take a look at them after the course of this webinar and after some time answer them, and we'll be able to post them up on the TeamSTEPPS portal. So this way everybody gets their questions answered. If for some reason everybody doesn't want to chat in questions and we don't get a lot of questions, we might open the lines for call-in questions at the end, but we really try to get people to do the chat so we can capture all the questions. If one of your questions is more logistical or more about technological issues you might be having, then definitely chat those in as you're having them, and we'll be able to take care of those behind the scenes for you. Just some quick acknowledgments. The project sponsors, thanks very much to Dr. Jim Battles from the Agency for Healthcare Research and Quality. AHRQ is part of the Department of Health and Human Services, and they're actually the organization that funds this webinar, makes it free, along with our national conference, our regional trainings, the development of new content, anything we really do. So thanks to Jim. Also thanks to Heidi King from the Department of Defense. DoD has always been somebody that has, from the start, been very involved in the creation and the maintenance of the TeamSTEPPS program. I actually didn't introduce myself at the start, I just realized. My name is Chris Hund, and I am Director for Clinical Quality at the Health Research and Educational Trust, and we are actually the people who run the national implementation of TeamSTEPPS with the funding from AHRQ. So thank you very much for joining us, and sorry I didn't introduce myself sooner. Also like to thank Impact International, David Baker, Andrea Amadeo, both of them, Danielle Emery, all help us quite a bit from the impact side of things, and so thanks to our partners there. Just a little bit about the TeamSTEPPS program before we jump in to make sure everybody's on the same basis. TeamSTEPPS, we offer master training courses. They're 2-day courses. It's a train-the-trainer approach. So basically what we're asking people to do when they come to our courses is to wear two hats. One hat is they're going to be learners, and they're going to learn about the TeamSTEPPS tools and strategies so they can take those home and teach others. The other hat we like them to wear is to really understand how they could use TeamSTEPPS in their hospital to improve some sort of quality of care or patient safety issue. We really try to help people in these courses connect the dots between how TeamSTEPPS can be utilized with whatever other projects they're working on in their hospital. So that's what we offer, these master training courses. And while the courses are filled up through September, there will be more offered after September. The dates aren't up yet, but there will be many more opportunities for people to attend the master training course. Some upcoming events. Right now we have webinars scheduled through September 2015. You can even register already for the August webinar, which focuses in on TeamSTEPPS in emergency departments with folks from Metro Health in Cleveland. Like I said, we've got master training courses. There's also an online course. So if you're not able to travel, or if you don't want to wait until the new courses come out and the new availability happens, you could sign up for TeamSTEPPS 2.0 online master trainer courses. That URL right there is where you go to register. So that's a very good opportunity for you. It goes through the same material. It's based on a 2-day master trainer course. You can learn about all of this and register for things at teamsteppsportal.org. Just a little bit more from me, and then I'll switch it over to the main event. If you ever have any issues with TeamSTEPPS, if you have questions about the program, or if you have questions about the content or how you might be able to utilize TeamSTEPPS in your institution, you can give us a call at that helpline right there that we have up, or even better, email us at arcteamsteps@aha.org, and that's the email that we could answer all kinds of questions that you might have, and we try to get back to you within a day. If you have questions, like I said, about content, we have some new courses, an advanced TeamSTEPPS course, office-based care TeamSTEPPS course. Questions about any of those things, that email address is your best option. Okay, so I'm going to now very happily introduce Dr. David Feldman. He is the Senior Vice President and Chief Medical Officer at Hospitals Insurance Company in New York, also the Chief Medical Officer at the FOJP Service Corporation. I think you're really going to enjoy Dr. Feldman's presentation. I know that he has always garnered rave reviews. He's presented at the TeamSTEPPS conference before in person. This is his first webinar with us, but people always are very interested in what he has to say, and so I'm very happy that he's here for all of you today, and I'm going to turn it over to you now, David.
Thanks very much, Chris, and good afternoon, everyone. This is my first webinar with these folks, and I do want to thank AHRQ, as well as the folks at HRET and Impact for inviting me. It's really an honor to be with you today and to talk about some of the work we're doing here in New York City with a bunch of large academic medical centers. You'll forgive me, it is a webinar. I can't see anybody. It sort of harkens back to my days in radio and college. Of course, nobody listened. Here, at least I know there's a few hundred of you out there, so that's good to know. Anyway, let's move on. A little bit about the objectives, what we're going to talk about today. We're going to describe how a malpractice insurance company can facilitate surgical collaborative that hopefully reduces risk and improves outcomes, how to achieve high-level engagement with clinical departments in a multi-hospital collaborative. I'll discuss some of the components of a multifaceted safe surgery program and where TeamSTEPPS fits into this. This is a TeamSTEPPS webinar after all. And finally, we'll talk about some metrics. I think everybody's always interested in how you measure these kinds of things. And we'll talk a little bit about how we've done some of that as well. So first, let me do a little audience polling to get a sense for who you are. So if we could bring up the first audience polling question, please. Are you a nurse, attending physician, resident physician, patient safety officer, risk manager, quality manager, another healthcare provider, I apologize to those of you who are in the other category. There's obviously lots of different folks who are involved in this, so please excuse my brevity here, but we're just trying to get a sense of who you are. So take a minute or two to just vote. Thank you. Okay, I think we have a pretty good idea of things, and probably a lot of you out there who are looking at this are going, well, once again, where are the doctors? And I think that's a fair point, and I think that's something that you'll hear about as I go into some of the ideas that we've come up with here to try and engage physicians more in patient safety efforts in general. My next question for all of you is the following. How much experience have you had with TeamSTEPPS? Are you a novice? That is, you've had little to no formal training. You've had some formal training but little practical experience. Are you pretty advanced? You've been using or promoting skills actively, or are you an expert? Are you teaching, evaluating, coaching, speaking on the topic of TeamSTEPPS? Where do you fall in your TeamSTEPPS experience? Okay, looks like we're getting a pretty good smattering across all levels. That's great. So a lot of you have had a lot of experience. Some of you had none. I hope all of you will find the comments that I'm making interesting and hopefully inspire you to do more to improve patient safety. So let's go on to the next question, or the next topic. What I want to do today is talk about sort of 4 areas. I'm going to tell you a little bit about who we are at HIC, a little bit about our program. Then we'll talk about a malpractice data review around surgery, where we came up with sort of these ideas. Then I'll talk about the surgical program itself and where TeamSTEPPS fits in. And finally, again, we'll talk about measurement. And as I said, we're hoping to have some time at the end to answer your questions. So to begin with, who are we? Well, we're a fairly big system, if you want to call it that. In essence, we really are a self-insured program. We manage a self-insured program, malpractice insurance program, which is not unusual for large academic medical centers. Most of them have their own program. And we've been doing this for going on 30 years already, so it's a program that's been around for a while. What has changed recently in New York and, frankly, everywhere around the country is this consolidation around medicine. So now you can see we used to have Mount Sinai, Montefiore, Maimonides, and Beth Israel, and now Beth Israel is part of Mount Sinai, and Montefiore is acquiring hospitals up in the Bronx and in Westchester. We still have Maimonides, and Bronx, Lebanon is a hospital we insure, although they're not owners. But the rest of the hospitals are owner clients. And that really creates a sort of ripe environment for doing this kind of work, since our incentives are aligned. We want to do things to reduce risk and improve the bottom line in malpractice, but all of this, any resources, all the benefits go back to the hospitals, which are all not-for-profit. Here they all are in New York. So they can do more to spend more money on nurses or equipment or whatever it takes to improve care to the patients that come to them. And this is a little bit about our demographics. It's a fairly large system. We've got almost 2 million inpatient days. This is from 2014, over 1 million ED visits, and you can see it's a pretty large group of providers and obviously of patients as well. Relevant to today's discussion, we do over 140,000 surgeries each year combined throughout all of our hospitals. And for those of you in the surgical fields, you'll understand that most or half are ambulatory. That's pretty typical. More and more surgeries becoming ambulatory. And the other half is divided between those patients who are already in the hospital when they have the surgery and those who actually come in the day of surgery and then stay. So this is a fairly typical demographic for surgery. So what can we do to reduce premiums? After all, we're a malpractice insurance company, and there's really 3 ways to look at how we can reduce premiums in malpractice. The first is to spread the cost, and actually that's something that happened here in New York a couple of years ago with something called the Medical Indemnity Fund, basically a fund that's sponsored by the state that pays for the future health care costs of neurologically impaired infants. Now, why is that significant? When the malpractice case involves a baby like this, more than, or at least half of the costs of the malpractice suit, which can be in the $10 to $15 million range, more than half of that is typically for spending on future health care costs. So if we can have that paid by another mechanism, that, as you can imagine, reduces the cost or spreads the cost around. Where is this money coming from? Well, obviously the hospitals and others pay into this fund to help fund these costs, but ultimately it's spreading the cost around to others. So that's one way of reducing premiums, and that really did for us. The other is to cut the cost, and here we're really talking about caps on pain and suffering and others, and New York State does not have this, but some other states do, and that will just cut the cost from a higher level to a lower level based on caps on pain and suffering and other mechanisms. But finally, what we want to focus on is preventing the cost in the first place. And as clinicians, I think all of us are interested in doing this, since after all, what we really want to do is make hospitals safer. We want to become part of the higher liability industries that we really seek to do. And to do that means really talking about patient safety, risk reduction, and so forth, and improving quality. And if we can reduce the numbers of malpractice cases, that really is the win-win for everybody, less spent on malpractice, and safer care for patients coming to our hospitals. So that's really what we want to focus on, is preventing the cost. And here's a summary of frequency of claims. That is the number of claims. And you can see surgery represents a third of all the claims that we've had. This is a 10-year period. We usually can't look at the last few years because of the statute of limitations, but you can see surgery is far and away the highest cause of the number of claims, with obstetrics and other departments sort of falling behind. And then if you look at the cost, the amount of dollars spent, again, surgery is about a third. You'll notice obstetrics sort of doubles, and that's because the cost per case in obstetrics is so high that they represent 16% of the cost, but only 7% of the number of claims. But again, surgery represents one-third of all the costs, and this, as you might imagine, in New York is a lot of money. So what do we do about this? Well, I guess the first question to ask is, where is this coming from? What do the malpractice data reveal about where surgical cases are coming from? I guess I would ask you first, where do you think it'd be coming from? Where do you think the biggest cause of malpractice in surgery is? Is it from communication? Is it clinical judgment? Or is it technical performance? I realize these are broad categories, so do your best, take your best stab at where you think the biggest cause of malpractice are in surgery. So, not surprising, when talking to a group of folks in the context of a TeamSTEPPS conference, overwhelmingly you think it's from communications issues. And I think, for the most part, you're probably right. If we take a look from our lawsuits and alerts here at HIC, communication and teamwork are really common agents of loss. It's really probably the most common. We also noticed a couple of other things. Postoperative patients. There's the concept of failure to rescue. There's data that I'm sure many of you are familiar with that show in hospitals with similar morbidity rates, that is, their complication rates are the same. Some hospitals have higher mortality rates than others, and that typically speaks to a failure to rescue. That is, patients having complications, but the inability of the team to recognize it early enough or to act quickly enough, and patients do worse than they might have had the team been aware of this and ready to intervene. And then there's the problem of the obese patient. I think many of us, certainly here in New York, feel that obesity is eclipsing smoking as a risk factor for healthcare in general, and certainly for surgery. There is data to show that just being obese is a risk factor alone for even the most common of surgical procedures, and that's something we found in our malpractice review. And then finally, not surprisingly, probably true for any malpractice company, poor documentation. But we also asked our hospitals what they saw in the world of surgery, and there were cancellation rates for inpatients, patients who are in the hospital already, for having surgery, from 6 to 17%, and many of these are due to an inadequate or incomplete preoperative assessment. There's a lot of variability in these assessments, so-called clearance, which really is a horrible word to use, but there's lots of variabilities, and I'll show you an example of that. And then this point, which I think really speaks to the value of teamwork training, something happens in an operating room, and when there's a root cause analysis, when people look into the case, they find out that somebody knew something but didn't say anything. And that, I think, really speaks to the value of communication, of teamwork, and empowering people to say something when they see something that doesn't look right. And we've seen that. Our hospitals have seen that as well, not surprisingly. Postoperative patients, We know, certainly in teaching hospitals, that typically patients who stay in the hospital tend to be sicker, and who manages them? Unfortunately, it often turns out to be nurses and residents, as the attending physicians are often either back in the OR or in their offices, and that's a problem. And then finally, the isolated case of these obese patients, again, who, when you combine obesity and a propensity for obstructive sleep apnea with narcotic medication, disastrous results can follow, and that's something that our hospitals have seen as well. So this is a typical example of what a medical clearance might look like, and you can see it's just a prescription pad. Nice that they included the vital signs, and then the one statement, patient is cleared for surgery. Not only is this inadequate, it's really almost dangerous, giving people a false sense of security, so we don't want to do that anymore. We also looked at some data from CRICO. Many of you are familiar with CRICO, the company that insures many of the Harvard hospitals, much like us, a self-insured program. They have the advantage of having a comparative benchmarking system. They look at hundreds of hospitals across the country to really look at what the causes of malpractice cases are. And you can see in surgery, clinical judgment is high on the list, technical skill not far behind. Communication is also important. This data is from 2009. I wouldn't be surprised if communication goes up even higher as time goes on and we get better with skills. But clearly all these things play a role in surgery data from CRICO. Also, if you look at communication between providers, between different groups of providers taking care of patients, a significant number of cases in general surgery, orthopedics, and neurosurgery are related to poor communication between providers and monitoring of the patient status after surgery. So given all this, how do we come up with this program to try and improve safety, not only to just reduce malpractice costs, but actually to improve safety in surgery for the sickest patients? Well, what we did, like many others have done, is we tried to combine a sense of where we see adverse events and safety issues in hospitals with our malpractice claims, and really focused on two different areas. I would argue the two things the only two things you have control over when trying to implement a safety effort, and that is fixing the system or improving the way that people who work in the system work with each other. And that really is the essence of what we try to do. So here is our surgical safety initiative, and it really sort of maps the course of a sick patient having surgery. Before surgery, improving on the evaluations they have before the operation, improving care during the operation by improving teamwork training in the OR. What happens to these patients after surgery, the patients that stay in the hospital, and we created a co-management program that I'll tell you about. And finally, the special case of the obese patient, creating a care map and trying to increase awareness amongst surgeons and anesthesiologists about the special needs and the special risks that obesity imparts on any patients having surgery. So here's the first part of our Preop medical assessment program. The details, of course, are not relevant here. However, we created two pieces. One was a reference document, and we got a group of hospitalists together, perioperative hospitalists. It's really a fairly new specialty in hospitalist medicine where medical physicians are experts in taking care of surgical patients. And they put together a reference document that goes system by system on what the current literature says about managing perioperatively comorbidities such as diabetes and high blood pressure and so forth, not focusing on just cardiac, which tends to be where many of these things are focused initially. We also, of course, created a form that goes in the chart. Now, obviously, our hospitals, like many of yours, are slowly and with force going to electronic medical records, so the format may look different. This was the initial version on paper, but obviously it may look different in an EMR. But the critical thing to see here is that there is a attending medicine physician who's signing off on this. Residents in medicine will often do the assessment, but a medical attending is always signing off. There's documentation that somebody on the surgical team was talked to about what the medical assessment found, and then perhaps most importantly, the surgeon needs to sign off on it, and the surgeon has to make reference of this assessment in his or her preoperative note. I've reviewed the risk, benefits, and alternatives of the patient, including the preoperative medical assessment done by Dr. So-and-so, discussed this with the patient, they've agreed to proceed, and so forth. And that really speaks in the chart to the fact that there's communication between all the members of the team. So you now have three experts opining on the best care for a patient before surgery. You've got the surgeon, of course, and the anesthesiologist, of course, and now a medical physician with expertise on all the patient's other medical problems. And this really is just for the sickest patients, ASA 3 and 4 patients. It's not really necessary for healthier ASA 1 and 2 patients. And then moving on to team training, all of you are familiar with TeamSTEPPS. To a certain extent, we custom designed a program to take champions off-site for a day and a half, give them the content, but also give them coaching. and have them do a needs analysis for their individual areas. So each hospital picked a multidisciplinary group of champions, that is surgeons, nurses, anesthesiologists, and others, residents, to talk about what the content of TeamSTEPPS is, how it would work best in their environment, and how they could help their colleagues to take these skills and really use them on a daily basis. The multidisciplinary faculty and participants. And this is what it sort of looks like. You could see we sponsored this off-site at a local conference center. It's important, I think, to get people out of the hospital where they can really focus on what they're doing. And you can see that a lot of it is just the content, but at the end you can see coaching sessions, a breakout session, a SWOT analysis, strengths, weaknesses, opportunities, and threats, really for their particular ORs. What is it works well and what is it doesn't, so they can really plan what their next steps are and prioritize what part of TeamSTEPPS would really be the place to start for them, and they all could do it differently. And in fact, they did. Some hospitals, I mean, ORs really have an advantage because every OR that I've ever seen has a late day. That's typically when the surgeons have their M&M conferences, the anesthesiologists have theirs, the nurses have their in-services, so people are there, but they're not working per se. And if we can get that time reserved, maybe once a month, to do these kinds of teamwork sessions, get everybody in the room together and train them, that's really an ideal time to start talking about how the OR team, can work better together. Each hospital trained anywhere between 800 and 1,200 staff. The best sessions were videotaped for those who couldn't make it or for people coming in new, and we were able to validate from our hospital chief medical officer and chief nursing officers that 100% of the OR staff received the training. So a lot of people in surgery at our hospitals obviously had the training. But that's not really enough, and we'll talk a little bit later when we talk about metrics about what happened after that, because I think training people is not really sufficient. The co-management program we actually did in vascular surgery, there is data to show that when geriatricians and orthopedic surgeons co-manage hip fracture patients together, results are better, patients are more satisfied, so are the staff for that matter. It's a very positive thing, but nobody's ever shown this to our knowledge in vascular surgery, and these are very sick patients, as you can imagine. So we basically created a co-management program where hospitalists teamed up with a vascular surgeon, and we purposely picked the right kinds of surgeons and hospitalists, people who understood what we were trying to do. We didn't want to have the hospitalists just become another intern on the surgical service. Rather, they were medical experts to help give care for medical problems. Again, these are only really ASA 3 and 4 sicker patients after surgery. They participated in daily multidisciplinary rounds, and we're at now probably greater than 200. We're probably closer to 300 patients a month that are being co-managed. We've actually expanded this. It's been so successful to other services besides vascular surgery. But the idea is to have one FTE, one hospitalist dedicated just to take care of 10 or 15 sick post-op patients. They're not doing anything else. They're not running to the ED to do consults. They're not seeing other medical patients, just taking care of these post-op surgical patients, sick surgical patients. And all this was accomplished with a written agreement. We really learned a lot from the Society for Hospitalist Medicine. It was very helpful to use this model. And then we created a care map for obese patients. How do we do this? We met with bariatric surgeons who probably understand the care of obese patients having surgery better than anybody since they're operating for obesity. And we met with them and said, tell us what you do, best practices, before, during, and after surgery for obese patients. And they went through this list, as you can see. And what's interesting is many of them also did general surgery. They do gallbladder surgery and appendectomies and hernias. And we asked them if they had obese patients having those kinds of operations, would they follow the same protocol? And the answer was no. And we were sort of shocked by that. And it led us to realize that it's very likely that other surgeons, those not as attuned to the needs of obese patients, such as plastic surgeons, ENTs, urologists, orthopedists, certainly weren't paying attention to this either. And we saw some of this, obviously, unfortunately, in our malpractice data and in our hospital event data. So we created this, and really this was an awareness campaign to really try and get surgeons and anesthesiologists and others taking care of surgical patients who were obese to recognize the increased risk they had and to consider things like preoperative DVT prophylaxis where maybe they hadn't before. So those are the 4 pieces of our surgical initiative. I want to talk a little bit about measurement tools, but before I do, I want to ask you all a question. The first question is, how do you measure your patient safety initiatives? How do you measure your patient safety initiatives? What do you think is the way that your hospital does that? Do you collect outcome measures? Do you collect process measures, structural measures, staff attitudes, or all or most of the above? How do you collect data? What kind of data do you collect to measure your team training or safety initiatives in your institutions? Okay, great. So most of you use all of them, or most of them, and a number of you focus mostly on outcome measures. Let's take a similar question and ask you, because this is what you do now, the next question is, what would you like to do? What do you think is the most important to collect? Sort of your ideal state. Think not about where you work, but what ideally would you like to have? Is it the same or is it different from what you actually collect? Okay, great. Looks like we have similar responses. I think most of us in the patient safety world agree that you really need all four of these things. First of all, it's not practical, if nearly impossible, to actually measure all of these things for any safety initiative, and some of them are just not as reliable as others. So our feeling is you need all of this. And I think you'll see in our initiatives, we use little pieces of each of them depending on the initiative. So our pre-op medical evaluation, we have folks here in our department here at HIC who audit charts, looking at surgical charts. They take a sampling of them. And when we first started doing the pre-op medical evaluation, we looked at the presence of two things. One, was there actually a pre-op medical evaluation, the form or something that looked like it in the chart? And two, this case compliant means, was there a surgeon's note that actually referred to this document? And you can see from the beginning when we first started in January of 13, towards the end of 13, we're getting pretty close to 100. I would say for now, probably it's probably at 100. The forms are all there. Now the question becomes, what's the quality of the forms? And that's obviously the next step, but we had to start somewhere with creating it to begin with, since when we started, this kind of thing was sort of all over the place. Everything from those prescriptions I showed you to very long and thoughtful pre-op medical evaluations, but made it difficult for anesthesiologists to look at. So that's a good question, actually. What do our anesthesiologists think? In the end, they're sort of at the sharp end of this program, this preoperative medical assessment. They're the folks that are seeing these patients in the holding area before surgery, trying to determine do they have all the information they need to adequately take care of a sick patient who's having surgery. So we asked them, and you can see this is a before and after. Before we started with the pre-op medical evaluation, and then after, we surveyed hundreds of anesthesiologists, attendings, and asked them, were all preoperative medical problems identified when I first evaluated the patient? Were all medical problems adequately addressed when I first evaluated the patient? And were all relevant consults obtained? Now, the numbers may look small to you, but let's remember, this is over 140,000 operations, if you will, even if you take away the ambulatory cases, because these are inpatients, and if you take away the healthier patients, these percentages still represent thousands of patients, sick patients, for whom an anesthesiologist didn't have, when they first saw the patient, adequate information. And you can see afterwards those numbers dropped. But maybe more importantly, we also asked anesthesiologists after, of course, after this was already implemented, do you think it actually enhanced the management of your patient? Overwhelmingly, for the sickest patients, again, these ASA 3s and above, almost 80% either agreed or strongly agreed with the statement that this pre-op medical assessment enhanced my management of the patient. Now, admittedly, this is survey data, but it's challenging to try and look at isolated improvements in care based just on a pre-op medical evaluation. But obviously, we've got other initiatives in place, and frankly, so do our hospitals. They're all doing things on their own to improve surgical safety. But this seemed to suggest that this was a beneficial program. I told you that we did training of OR staff in TeamSTEPPS, but I really don't think that's enough. Neither do the clinicians that we work with, the leaders in our hospitals who we meet with on a weekly basis to talk about this initiative. And we decided, rather than doing surveys to see if our OR team members were actually using the skills they learned, we did OR observations. And we really sort of took off on a concept that was written about in the Joint Commission Journal about a year and a half ago, called the Medical Team Performance Assessment Tool, the MTPAT. And really what it is a tool to use for observers watching a teamwork event and trying to decide, are folks using the skills from TeamSTEPPS? So we challenged a group of surgeons, nurses, and anesthesiologists to get together and look at the 25-odd TeamSTEPPS skills that you all are familiar with. In TeamSTEPPS, you know, the 5 categories: team structure, communication, situation awareness, situation monitoring, leadership, and mutual support. Each of them have about 4 or 5 skills in them. So which of those 25 are the most relevant for a proxy for a teamwork event in surgery, which we all know is a timeout or a briefing? I really view them as one and the same. It's a planning event that happens, I dare say, in every operation we do in our institutions. The quality of them is another matter, but certainly they happen. So why not use that as a proxy for a teamwork event? And let's choose the things that we think are the most important. And here you see them. 9 questions. A leader is established and a timeout is called. Recognition of team membership. All of these things have direct correlations with the 9 or so TeamSTEPPS skills right from TeamSTEPPS. So we had observers watch operations and rate the team. We try to make it simple to try and encourage inter-rater reliability. It's a yes or no question for all of them except for question 3, which is did people introduce themselves, or recognition of team membership. And we gave them partial credit if some of the people introduced themselves. But you can see here's an example from one of our hospitals where we had different observers, because we asked, would there be some Hawthorne effect? Would there be a different response of the team if they knew a nurse was watching versus a doctor versus an administrator? Most of the questions, as you can see, are pretty similar. Perhaps the question active engagement, question 8, looks like the nurses maybe had a slightly lower score. Is it possible that nurses were not regarded as highly by the team, and people didn't pay attention? Hard to know. But we also did this both live and with video, and again, there really wasn't much of a difference in the results between a live observation and a video observation, which sort of says that maybe this Hawthorne effect really doesn't matter so much. The teams are going to do what they're going to do regardless if they think somebody's watching them or not. But we're collecting this data, and this data is used in a couple of different ways. Some of our hospitals have gotten folks together in a grand rounds atmosphere with surgeons, nurses, anesthesiologists together, said, look, over the last 2 months we've done hundreds of observations, and here's what we found. We do really well on these things, but we really can do better on these other things, and let's all try and work on those over the next few months. Some of this is individual feedback. That's the one advantage of doing live feedback. And in one of our hospitals, actually, teams of observers went around. A chief of service, a surgical chief of service, along with a nursing leader in the OR, went around observing. That alone sends a great message to everybody that this is important enough that the chiefs of surgery are actually interested in watching people do timeouts. I thought it was a great message. Also gives people the opportunity to do immediate feedback. Those of you working in ORs know that OR teams change fairly frequently. In fact, right after the incision is made, often there's a change either in the nursing staff or anesthesiologist. And so it's that time that you want to, while the team is there, that you can give them immediate feedback on how they did. Of course, you have to pick the right operation. You don't want to be delaying surgery unnecessarily. But spending 15 or 30 seconds to give a team feedback, it can be very valuable. It's on the spot. It's real time. And I think it really speaks to the importance that an OR places on this kind of activity. So we're doing this now not just for briefings, but for debriefings. Obviously, a debriefing or a sign-out in the WHO language is much less frequently done. It's not required by anybody. I think it should be. Many of us know or feel that a debrief is really the most important tool in all of TeamSTEPPS, so we're really encouraging that. We actually provided some resources for this. We use a tool called Checkbox. It's sort of like a SurveyMonkey type of program where the server is located here, so we have control over it. And you're able to answer or send back data on a phone, an iPad, any device, a PC. We collect the data, and we send out weekly reports to our hospitals on how they're doing, and we're able to actually have them benchmark against each other. So it's really been a great way of trying to give feedback to teams on how they're doing using the TeamSTEPPS skills that they learned. And I think that's really it's a lesson that we learned in not just giving people the skills, but actually helping them to use them more. Let's talk a little bit about the co-management results. Again, some survey data. We did some nursing surveys. Here you can see the questions that we did, focus on questions 9 and 10. I think those are the most interesting. We asked nurses, did the presence of a hospital improve care for these vascular surgery patients? Did it make it easier for them to do their job? Here's the results from one of our hospitals, and you can see the before and after. And overwhelmingly, nurses thought this was a positive program, up to, well, it's a 4.5 or 5 out of 5. thought that it really improved the care they could give their patients and helped them make their job easier. I think all of us can imagine why that would be. Maybe more importantly, we actually looked at some outcome data. And here we used the NSQIP, that's the National Surgical Quality Improvement Project. I'm sure you're all familiar with that. It's really become the gold standard in looking at surgical outcomes and morbidity and mortality as risk adjusted. We used the risk calculator to try and develop O to E ratios, both before the co-management and after. And you can see the numbers are small, so only in 2 areas did we actually see statistically significant improvement. We started out doing pretty well, right? We want to be at around 1 or below. That means we're doing better than expected. And our hospitals on average did at least as good as expected. In some areas, maybe a little better. Maybe one area in cardiac, maybe not so well. But after the co-management program, and this is a couple of years later, with the same types of patients, same vascular patients, the same surgeons, and you can see really significant improvements. Whereas now we went from, I guess you could say, we went from good to great, to coin a phrase. And this has really been a very positive thing, and that's why we've decided to expand this. Interestingly enough, you can see that surgical site infection didn't change. But I suppose if you asked why that might be, it's hard to imagine for a typical clean operation where most of the cause of infection is probably some break in technique in the OR, that a co-managing hospitalist would have an impact on that. So I guess that sort of makes sense. The urinary tract infection, not sure why that would be. We did interview our NSQIP coders, the SCRs, the surgical case reviewers, who actually collected all this data, and they did note that the documentation was significantly better once we had hospitalists documenting in patients' chart. That probably wouldn't surprise anybody. In fact, case mix index went up in these patients, probably for the same reason. That may explain why urinary tract infection went up. Maybe it's not something that the surgeons and surgical house staff are documenting as well as a hospitalist would. But more to come on this. This is really just a pilot and very exciting. And finally, the obese patient survey. Surveys we did. Here we surveyed surgical and anesthesia attendings. And the first question we asked them in 2012 before we started was, what do you consider obese? Fascinating, 25% didn't even use BMI as a way to measure obesity. Well, that certainly tells you something. Another 13%, I guess, thought I was obese. My BMI is about 26. So that was kind of a little bit disturbing. But then we look afterwards, and you can see that, first of all, less than 5% actually thought you should use something other than BMI, so that was certainly a positive. And now you've got a significant number falling into the range of 30 to 40 or over 40, which, of course, WHO definition is greater than 30. Of interest, you may recall when I showed you the obesity care map, it was for patients with a BMI over 40. We picked 40 because I think we felt if we started with a BMI over 30, the WHO definition, to be too many patients to have to do this with. I think what's happened is a lot of folks have sort of made the equivalent that maybe that's the definition of obesity. But either way, it certainly looks like there's increased awareness. More importantly, did they change their practice? So beforehand, it was rather surprising to see that actually even 12% of anesthesiologists did not change their practice for an obese patient. More interesting, 32% of surgeons did it. Here we are afterwards, and now we've got 97% of anesthesiologists and 84% of surgeons, statistically significant improvement in do they change their practice overall when they have an obese patient that they're taking care of in a surgical procedure. So preliminarily, it looks like we've done well in increasing awareness of the problems that obese patients face in surgery, and we're moving on to some of the next phases of this. Finally, of course, to measure outcomes, as I mentioned, NSQIP is a great tool to use that. This is a sample report. All of our hospitals were part of the NSQIP program before we started this. We became a collaborative, which, interestingly enough, reduces the fees they have to pay. The college really looks for these collaboratives. And so we get these reports. They're delayed by about 6 months, so we're just starting to look at some of them now. This is sort of a sample of what they look like. There's sort of various ways of presenting them. Each of those yellow dots on the bottom chart represents a different hospital. Again, this is a sample report. It's not ours, but this is the kind of data we'll be getting. So we'll be able to benchmark our hospitals one against each other and actually see whether outcomes have improved. Now, again, the problem with looking at just outcome data like this is how do you know that this is the cause of the improvement? Obviously, if our hospitals do better, we'll all be very happy about that. Could we say that it was because of this initiative? Well, I think it's global enough that we could probably say it was a part of it. But to say it's directly as a result of this, I think, and that's the problem with outcome data unless you have a randomized prospective double-blind study, which, of course, is difficult to do. We've also done some qualitative review. Every 6 months or so, we get together with this team of physicians from our hospitals who have been working on this with us and do a review of our malpractice cases and alerts that get sent to us from the hospital risk managers, and we ask, would any of these projects, did they make a difference? Were they in effect at the time? The red things you probably can't see the details on, but the red things are yeses, and they relate to teamwork, and it's pretty common. So not surprisingly, even the subjective data seems to suggest that teamwork is still an issue, and this is, this battle is far from over, but I think we've made some inroads into it, and certainly TeamSTEPPS has been a big part of it. So some general themes in summary. Most safety initiatives involve multiple strategies. I think TeamSTEPPS is a great tool. We use it a lot in many of our other initiatives, but I think it has to be part of a bigger, more global look at how you can improve safety in a particular area. And TeamSTEPPS is likely to be the core since we know so much of what goes wrong relates to communication and teamwork. Involving attending physicians, I don't have to tell all of you, is the most challenging, even full-time doctors. I think part of our problem in healthcare now is physicians, certainly of my ilk, went into medicine to a large degree because of the autonomy that physicians have. And I think autonomy taken to the extreme, unfortunately, creates too much variability, and that prevents us from being a high-reliability industry. So that is a challenge. And then, although high-risk areas are a good place to start, if you're a patient, it doesn't really matter where you are. You want to have the safest care possible. So I'd urge you to think about that as well. So that concludes my formal remarks. As promised, we have a little over 10 minutes for some questions. And Chris, would you like to moderate that?
Yeah, definitely. Thanks a lot, by the way, David. That was a great presentation. I know we'll get a lot of questions that will start flooding in as we do this, but what we have so far, a couple different categories. So I have some questions about your actual, when you started and were doing the training process. So I think we'll start with those. So when you were training the OR, who all did you include in the training? I think that's where we'll start, and then the second half of that is, were individuals like the PACU staff involved in the training as well? How did you separate folks into, or did you have them as interdisciplinary groups? How did you do that?
Well, that's a great question, and I will start out by saying there's no right answer. We certainly encouraged, hard to say that hard to use the word demanded, but we really encouraged multidisciplinary learning. I really believe it's hard to get people to work in teams if they're not learning in teams. That's why I think team-based learning in med schools and nursing schools is such an important tool. But we did that, and we were able to get our hospitals, certainly in our surgical initiative, to agree. So all of the off-site train-the-trainer sessions with champions were all multidisciplinary. Always had surgeons, nurses, anesthesiologists, a couple of residents, anesthesia and surgery as well. The question, of course, is where do you draw the line? And depending on the hospital's perceived needs, some included PACU folks, some included ICU folks. And we left that really up to them. I think you know this, Chris. Probably when TeamSTEPPS started, the idea was to train the whole hospital. People rapidly realized that's very hard to do all at once. Taking one department at a time is probably fine, but you have to draw the lines as artificial as they are. What's happening now, and which is really so great to see, we've already done all the same kind of team training in OB. We started in OB, in surgery, of course, and in our emergency department. And now we're starting to do multidisciplinary simulations at some of our hospitals where they can actually practice TeamSTEPPS skills across departments. And that's really where the money is. That's where, if you're a patient, you don't really care where these people are from. You want everybody speaking the same language. But that's not to say that there's been, I've read some literature where they've trained nurses and surgeons separately, and they've gotten success with it. I just think it sort of belies the whole point of this, which is to get people to work together. So that's the way we did it.
I agree. Yeah, definitely. I think probably the right way to go about things. Somebody asked the question of, and this is a question that I'm sure you've been asked before about engaging physicians. How do you get them to overcome barriers? And I think this goes past training, because especially at the OR, you said you were doing your training when there were those later start days, but just in general, getting them involved in TeamSTEPPS, getting them involved to the point where I've heard in the past physicians say, well, this is time away from patient care, or just, more time that I don't have. So how did you engage them to get them interested and to do this?
Yeah, that's the $64,000 question, right? How do you engage physicians? And I think it's like everything else. It's multifactorial. The first thing you need is leadership, and we're fortunate. We have people, as I mentioned, leaders from our hospitals who we work with closely on this. They're leaders within surgery, typically surgery or anesthesia, who understand the benefit of this, who are early adopters, innovators, if you want to call them that. And they have the support of the senior-most leaders in the hospital, the CEOs, the CFOs, and so forth. We provided some resources that were based on everybody doing this. That is, we gave some rewards, as many malpractice insurance companies will do, for participation. I know that CRICO does this also. So it's a bit of a carrot and a stick. Believe me, I was part of some of the, hour or two sessions at our hospitals. I had surgeons come up to me and tell me that I was insulting their intelligence, and so forth. And you're always going to have that. I mean, it's really like everything else. It's a bell curve. You have the people at the front end who really want to do this and are passionate about it. You have the people at the back end who say those kinds of things, and I try to ignore them, certainly at the beginning. And the great masses in the middle who could probably be swayed one way or another. But a lot of it is carrots and sticks. It's a requirement. As I said, one hospital had surgical chiefs walking around the OR saying, look, we're watching you do these. You need buy-in from the leadership, from physician leadership to make this happen. It's not a guarantee, but it's pretty hard to do without that. And if you can have some way of incentivizing people, that's tough to do. Even the resources we incentivized them with probably didn't get to the level of an individual surgeon. Maybe the hospitals did, and they, sort of provided the ruler, if you will. But ultimately, look, physicians don't want to be left out of the pack, and like everything else, if they look around and see everybody else is doing this, even begrudgingly, they'll end up doing it themselves. And then all, of course, you need is one or two examples of something that went horribly wrong or alternatively horribly right as a result of this, and then you'll convince anybody very easily that it's the right thing to do. So it's multifactorial, but you need leadership.
When you're talking about these, who's getting trained was definitely a case-by-case basis. What about what these individuals what the different hospitals were using? Were there certain requirements of the TeamSTEPPS overall collection of fundamental tools, or were they allowed to pick and choose and develop their own program for what they wanted to work on? How did you guys go about that?
I think what we said to them, as I alluded to before, is, look, each of your hospitals, forget the fact that each of your hospitals has a different culture. These are big places. I would venture to say each of your OR, pods, if you want to call it that, groups of ORs, your urology ORs probably look different than your cardiac surgery ORs, right? So we said to them, look, do this any way you'd like. Here are all the skills. And that's what we had at these train-to-trainer sessions, these off-site sessions. We devoted a lot of time for them talking amongst themselves about where they wanted to start. When we did this in obstetrics, a couple of our hospitals never did any formal training. They went back and said, look, we need to work on briefs and huddles, and for the next few months, that's all we're going to do. Then we'll get to SBAR and check back and so forth. And we told the surgery folks the same thing. For them, it was a little harder. Most of them did some type of formal training, but one hospital did it all at once in one day. Another hospital did 4 one-hour sessions spaced a few months apart. Everybody did it a little differently based on what they perceived to be the things, sort of the low-hanging fruit, where they wanted to start. I don't really think it matters. I think this is very cultural. Everybody's heard this before. You've got to start where you think your teams will benefit the most. So there's no prescribed way of doing this. We just said we got to do. And by the way, we constantly repeated to them was, look, this is not about TeamSTEPPS. This is about getting your OR people to work better as a team. TeamSTEPPS is just a tool. It happens to be one that a lot of people use. It's a uniform language, but it's a tool only to get people to work as a team. That's what we want to do, get people to work better as a team.
Right. Oh, that's great. That makes a lot of sense. There were, shifting gears a little bit here, I want to get to, a lot of questions came in around your observation tool, the evaluations you were doing about that. So a question right off the top, did the metrics you were using, did that permit teams to evaluate individual performance, or was there a way to drill down, or was it solely team performance?
It was both. And in fact, the information we got back, when we, as I said, we use checkbox. It's like a survey monkey thing. So each of the observers, and there were lots of them, they would actually, we have the names of the surgeons, the nurses, the anesthesiologists, everybody was in the room. The problem is even though we're doing thousands of observations, to drill down on any one individual, it's probably not enough data. You could do it by service, right? Some hospitals would say, you know, our cardiac surgeons folks are doing better than the ENTs or whatever it is, because there's enough of an N for that. We knew from the beginning there's not enough observations for any individual. Now, having said that, someone doing a direct observation, imagine a chief of service in a room with a surgeon in his or her service who's doing something that's clearly, you know, not participatory, shall we say. That's a one-on-one conversation that a chairman should do, right? But beyond that, I think the data just was, as much data as we had, it wasn't really enough to drill down on individuals, mostly groups and services.
Sure. So with your observations, you were talking about doing the video observations of recording people. Were people hesitant to being on video? And if so, what did you do to get around that? Did you need their I guess, you know, approval saying it's okay to video me? How did that go about?
Right. Well, as you might imagine, that's a very controversial question. Never mind the fact that everywhere else in society people are wearing video cameras. I mean, every few days in the news, it's all about policemen wearing video cameras. How many of us, myself included, have gotten a ticket from a red light that you went through? There was nobody there. It was just a red light camera. So it's the way of the world, and Marty McCary talks about the value of videos. Not all of our hospitals adopted this, Chris. Actually, one of our hospitals, the chief said, you know what, we're going to go around and observe. We don't want video cameras. Another hospital said we're putting in video cameras, and look, all hospitals have unions, and they got their participation, their buy-in. Patients are never identified in these videos, so that's really not an issue. And we let each of our hospitals decide how they wanted to do this. I think, you know, in general, there are pluses and minuses to both. I can't say one is better than the other. And we let our hospitals decide how they wanted to do it. We actually supported, we paid for either the video cameras or the people doing the observers, whatever they decided to do. We just wanted them to do observations. It's a tough question.
Yeah. So I think this is a good final question here. I'm trying to find a good final question, but somebody asked, what was the, you know, overall, was there some sort of reward that you guys, as, you know, your organization provided, you know, when people participated in training, or if their outcomes improved? What was that further carrot?
Right. Well, remember, we're owned by our hospitals, so in essence, the resources we're giving them are theirs, right?
Sure.
But we created a program with their approval to provide resources on the front end. So for this program, the surgery program, we paid for some of the FTEs to do the pre-op medical assessment. We paid for the off-sites for the trainer folks to go off-site to a conference center to be trained, to train themselves. We paid, as I said, for the observers, the video cameras. The co-management hospitalists, it was a 2 FTE program. Matching grant, we paid for one, they paid for one. Same thing with the obesity care map. So we paid for some of this on the front end. We've had, up until now, an incentive where if they meet certain process measure guidelines, they get a discount in their malpractice. That's a bit of a guess because we don't really know, you know, statute of limitations in New York is 2.5 years. It's hard to know what's going to happen. We'd have to wait a couple of years to see. But we gave them a discount. It wasn't huge, but enough of a discount. It's certainly more than pay for performance gives you. If they met certain process measures. Outcomes are tricky, as I said before. Unless you're holding everything else constant, how do you know that that's the cause of it? And we're monitoring them. It's just we're not basing the rewards on that. It's based on, as I showed the data on compliance with the pre-op medical assessment. Right now, the teamwork observations, all they have to do is do a certain number of observations. There's no requirement for passing or failing, and I don't think that's a good way to start. Ultimately, we might do that. But for now, it's just you do a certain number of observations, you give people feedback, and you get a little reward for doing that. So that's how we incentivize them.
Thanks a lot, David. There are other questions, and we'll pass them along to you. I think it's always a great sign that you did a great job, and everybody really loved the webinar, and we get all kinds of good questions. So I'd like to thank you a lot for joining us today, and it's the top of the hour, so I think we'll call it, and we look forward to seeing you all on our next webinar in August.
Great. Thanks, Chris. Thank you, everyone.
Ladies and gentlemen, that concludes today's presentation. You may disconnect your phone lines, log off your webinars, and thank you for joining us this afternoon.